So this is your chance to put some questions out on Glisser. I haven't been doing text. I've been actually seeing the Glisser questions coming up on my phone to start off with, and I think some of them may be coming up on the screen. But the most popular question at the moment to start off with is about data. So perhaps as I lead the data work stream, I should answer that quickly myself. I'm pleased that people think data is so important. I think data is really important, and I know Tony does as well. There's a big evolution developing data at the moment in terms of data quality. Ruth May, who's in the room with us, has been writing out to individual trusts. We have the CNST premium lever to improve data submissions to the maternity services data set, and we are seeing a massive improvement in data quality. I had a teleconference yesterday with people from CQC, a team from the NMPA, and NHS Digital, lots of different stakeholders in driving the development of our data viewer. I'm due to have a link sent today to start using the alpha version of the data viewer. I would see that coming out so that you can have access to the data and be able to see the national clinical quality improvement metrics on the data view, looking at our trust, see what quartile you lie in terms of your performance, comparing yourself with like-sized trusts. We've also got a big project coming together using a tool called iView Plus, which will allow you to interrogate the national data yourselves. Direct access to national data yourselves, and that will be coming live over the next year. So we are making massive changes in data. There will be a revolution in March 19 where the new version of the maternity service data set will come out, which will be so much more comprehensive. We'll be able to actually start to link care with individual units, with individual clinicians, and we will be eventually linking in with patient feedback as well. So data is going to improve dramatically. Do you want to do the next question?
Thank you, Matthew. It's interesting, isn't it? Some people have got their heads down, either tweeting, typing their questions into Glisser, looking at the programme. There's several devices going. I'm the same. And we're great multitaskers, but this is a really important part of the morning to be able to ask questions in this way. So thank you, Matthew, for responding to the data question. I think we're scrolling down the screen, so we've missed a few so far. So I'm just going to point to our speakers now, and I'm going to ask who may be best placed to respond to. There are so many current directives, many that merge, and it is really hard to stay on top of it all. Can they be joined up into fewer? And that question, I think, may resonate with many people in the room.
Well, I think I'm going to start with that one because that was a topic that we discussed yesterday at the Maternity Transformation Board where you were. And one of the concerns that we all have is that there are so many directives. And one of the examples that was being shared was a head of midwifery who had been given no less than 23 directives to turn around, all asking for similar information in the space of 1 year. And maths is not my greatest, but even I can work out that's one a fortnight, which is crazy. And I think what we asked the chair of the Transformation Board then asked us ask that particular midwife to go away and not go away, but to think about how you could compile a list, think about amalgamating them, and then prioritise, so that instead of being given 23 different requests from different bodies, that you would get a channel of requests saying, we need this information. And then, Matthew, I hope that you're going to tell us in the not too distant future that you can feed information into a single portal and that you can start diverging it in different directions.
Yes.
Yes, fantastic. And that wasn't planted.
It's the short answer. Over to you, Matthew, for the next
It's quite
question.
difficult to produce, but that's the vision, exactly what we want to do. So, focus is on smoking and diabetes as high-level harm, and yet many supporting organisations for the health agent don't provide weight loss, healthy weight support. Is there something that will improve in the future? Tony, can you want to start off with that one, and then we can broaden? Pleasure.
See what I'm getting. I think one of the focuses that we've had within the collaborative, and we've said this from word go and certainly emphasised it with all of the Wave 1 organisations, is what we're trying to do is to encourage you to do work that's within your gift as a primary piece of work. but that often creates a sense of step away from some of the more tricky problems. So when you're talking about diabetes, you clearly can't tackle that without having some eye on the obesity and weight loss problems that might be needed for women coming into pregnancy. And similarly, as a lot of services have, when you started to bring services together in health and social care, some of the funding for smoking cessation has then disappeared in some local systems. So it can derail the way that we are working to a certain degree. But the conversations I've had when I've been talking about this within local economies is to say we have an opportunity to do some of this improvement work that then casts a longer shadow on the areas that we can't influence, but it puts more pressure on those to happen. So if you're thinking about smoking, if you've got robust pathways for detection and screening of women, and you're having sort of the level 1 interventions about smoking cessation, you're then creating a much greater need to have more robust pathways for specialist smoking cessation within your local economies. Now, and if we're working at local maternity system level, and I think that's where a lot of our focus will start to shine over the next few years, those conversations become stronger, louder, but they're singular conversations. So instead of 3 or 4 organisations trying to have those, you're having them in one room in one way, and so they become much more simple. The diabetes one I think is harder, because I think we have very limited influence over how we can start to tackle more wider public health issues, but I don't think that stops us from having those conversations within our local maternity systems and at national level. But within the collaborative, I don't think we're directly going to be able to influence some of that, but what we can do is see change that's within our grasp. That's the word I was looking for.
Great, thank you very much, Tony. I'm going to move on very quickly. So the next question is about just how we link in the whole complexity. I'm not sure we can necessarily produce one graphic to join all these things up, but I think it's worth just thinking about the principle that, as I said before, there aren't any sort of single silver bullets to solve this problem. It really is about the whole system-wide engagement in this, and it's all about the accumulation of marginal gains, very much like the British cycling team approach. So I have seen some attempts to try and join those things up in a graphic, and we will work on that. But the complexity that's described in that question, I think, also reflects just the huge system-wide engagement. So although sometimes it's a bit confusing, it is fantastic we have such broad engagement.
Great, so our final question that we're going to respond to at this moment in time is directed toward Mandy, and there is something about keeping the momentum going after this 3-year period. So Mandy.
Yeah, no, I think that's a really important point, and I know that people coming out of wave 1 might be feeling a little bit anxious about that at the moment as well. It's a momentum that we really do have to keep going. So we hope that this collaboration is going to really sort of get you going and want you to carry on. How we can help, I think, as Lesley said earlier on, the Royal Colleges are the glue. We are the glue that will keep this together. We're the organisations that, regardless of what happens in the political arena, we're still here and we will still carry on being here. So I think that's probably a role that we can take part in making sure that there are links made, that there are networks set up, and that there's materials out there that we can share around through our networks and through our members to support you in your QI journeys.
Great, thank you very much. What I'm going to do is I'm going to actually talk to the NHS improvements in the NHSE teams about whether we can collect these questions up and see if there's a way we can put some answers out on the web or some other way to do that. But it's important you get your break. So we're going to have a break now for coffee. We're going to try and start again on time. The aim is to at least finish it on time for the day, or possibly even try to aim to finish a little early today. So don't worry about us running slightly late at the moment. Enjoy your break and look forward to you going to the breakout sessions next.
Absolutely. So there's 15 minutes now for coffee. We've eaten into a little bit of the time. So coffee for 15 minutes into your breakout sessions. Remember to reschedule your acute penine. Don't forget to look at the posters and enjoy the rest of the day. See you back in here at 3:15. Thank you.